Welcome, my name is Deanne Pelletier and I'm the Director of Annual Giving here at the Trust, and I am pleased to welcome you to our What's Up Doc today. We'd like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up Doc. The Walker Lecture Series offers a wide variety of programs on history, art, and science, as well as dramatic, musical, and literary performances. All events are free and open to the public and held at the Concord City Auditorium. We encourage you to check out their website to learn more. We are happy to welcome Dr. Mary Eckert. Dr. Eckert is a board certified in internal medicine since 2001 and in hospice and palliative medicine since 2012. Her formal education includes undergraduate studies in anthropology from Harvard, graduate degrees in international relations and business from Columbia University, and she attended medical school at the University of Pennsylvania in Philadelphia. After all of this, she completed her internal medicine residency at Maine Medical Center up in Portland. As for Dr. Eckert's work experience, she served in Peace Corps Liberia in a village-based healthcare program, did research and development at Pfizer Pharmaceuticals, was a hospitalist in hospice palliative medicine in Austin, Texas, and has been at Concord Hospital since 2010. I'd also like to welcome Amy Tremblay. Amy joined Concord Hospital in 2017 as an LNA on the medical oncology unit. She graduated with an Associate's of Science of Nursing from NHTI in 2019 and obtained her Bachelor's of Science in Nursing from Southern New Hampshire University in 2021. Since starting with Concord Hospital, she has worked in emergency behavioral health, cardiac critical care, the ICU, and the operating room. Amy joined the palliative care team in 2021 as the clinical resource nurse. She obtained advanced credentials as certified palliative care and hospice nurse in 2021. Earlier this year, Amy was a recipient of the Daisy Nurse Leader Award, and that recognizes nurses who are extraordinary in the impact they have on compassionate patient care. Congratulations, Amy. She is currently attending UNH to complete a Master's of Science in Nursing to become an adult gerontology acute care nurse practitioner at the end of 2024. Please join me in welcoming Dr. Eckert and Amy Tremblay.
Thank you, Diane. All right. Want to just park here?
Go for it.
Okay.
Yeah.
So, thank you very much for inviting us. Is this mic okay? Does it sound? You can tell from my bio, I grew up with rotary phones. And you can tell from Amy's bio that she's our tech person. So just let us know if you're having any questions. But we are with the palliative care team, and I guess we have to hit the button. We have no financial disclosures, and palliative care is something that's really dear to our hearts. We feel very fortunate to work in this field. And as we prepared this presentation, I actually asked myself, like, how long has this been around? I didn't even know. And I found that back in 1936, the American Board of Internal Medicine was established. And about 5 years after that, cardiology set themselves up as a specialty. It wasn't until 1990, about 50 years later, that the World Health Organization established palliative care as a field to help relieve suffering and improve quality of life for people with serious illness. It's kind of interesting. And then in 1997, it came to our country. So we have had board certifications since that time, and we're kind of a small but different subspecialty. So Amy will try to start with a good definition here.
Yeah, so palliative care. We are a specialty of medicine, like Dr. Eckert said. And what we do is we really focus on holistic care. We focus on patients and quality of life. And that means different things to different people. Really what we do is we're really interested in what makes our patients tick, and we want to focus on the care of those individuals. And those are individuals that are living with serious life-limiting illnesses. We can get involved with any patient at any age, any stage with a serious life-limiting illness. And really, it's a big fancy word, palliative care, but we do two big things, two main things. We break it down into two categories: symptom management and goals of care. And we're going to explain what that is, okay?
So for symptom management, that probably seems like an obvious thing. You know, it can include pain, shortness of breath, anxiety, nausea. There are a lot of physical symptoms that people get, and we're experts in managing symptoms because in healthcare, you've probably experienced this. You come to your doctor, you have a symptom. They ask you all these questions and do tests to figure out what's causing it. They try to fix it, and the symptom goes away. But our patients, the symptoms don't always go away. You can't always get rid of the illness or cure it. And then because of that, it creates some special challenges. And for our really seriously ill patients, we have a symptom that's not up there called existential distress, because you get sort of lost almost, you lose yourself in this overwhelming illness. You don't get enough sleep, and you may have experienced this, you know, with family members or yourselves. So we try to address everything, and that's where the holistic part comes in. The other thing to realize, and I don't think even many doctors understand this, is people say with advanced cancer, over 70% have serious pain that is uncontrolled. The other one was, I think, but the other part I was going to say is that we also learned from our research that for patients, nausea is more upsetting for them and disruptive of their daily lifestyle than pain even. So we try to pay attention to this. For people who are near the end of their lives, over 70% have delirium, which you may have been here for a talk on that recently, but delirium is a state of being confused, can be very hard on families and patients. So we try to help with all that.
And the other thing we do is that goals of care. So that's a really, it's less concrete than symptoms, right? It's a much more vague term. So what does goals of care really mean? For us, what that means is simply getting to know our patients, getting to know who they are, what makes them tick, what brings them joy, you know, who they are as people, and not just the list of the medical problems that they may be coming into the hospital or coming into the office with. We want to know more than that. Knowing that helps us really understand our patients. We want to get to know their families, and that helps us as well. Because then what we do with that is we can take all that information and then really help with figuring out what is a real quality of life for you. Because everyone's quality of life is a little different, and especially since that's what our main focus overall is. How do we improve your quality of life through symptom management and understanding who you are? We can really make sure that we're bringing our patients forward in their medical care, and we're keeping those ideas as we go through and figure out how are we going to treat this serious illness, what makes sense, how do we obtain your quality of life. We want to bring your hopes and your, goals, your dreams of what you're hoping to achieve in the short term or the long term right into the forefront of what we're working on. So we bring that to light early so that we can work on achieving it right on. And some of the things that we will, especially here in the hospital, a lot of triggers will kind of come up for like the primary teams in the hospital that will say, ooh, we need to have a goals of care conversation about this. And a lot of those are up here, things like feeding tubes and artificial nutrition, or really having just trouble making a decision. We're not sure which way to go. We kind of go back and forth going, maybe, oh, maybe not. A need for a major surgery or a really complex procedure that could have, very vast and difficult steps in the future afterwards. And unclear or lack of advanced directive documents, which we'll talk about further. So some of those things will prompt our primary teams to say, maybe we should sit down and slow down for a minute, get to know our patient and say, we need to maybe talk about what goals, what's really important to our patient so that we can help them make good quality decisions.
And that's a really good point. I like how you said slow down, because because the next part of what we do, which we call it complex medical decision making, but it's pulling everything together. First, what the patients and families are hoping for, but then what the medical team is telling them, because we don't always speak in English. I call us the common sense specialty, because we try to just get to the bottom line of this is what's going on, these are your options, this is what might happen if you take this path. And because sometimes we often rush over the potential side effects or complications of procedures, but we really have to talk that through, and it's hard to talk about these things, but we sort of have a hope for the best, plan for the worst, and we try to take our patients and families down each pathway. And we have to and so this is a time-consuming process, because usually now, I just talk about like the nuts and bolts of it. We get a consult, we go to the hospital to meet a patient who's never been in our system, but it goes to Dana-Farber in Boston and Dartmouth, and we have to get into all those EMRs and pull out information. We have to talk to all the specialists. Make sure I look at radiology reports a lot, because when we come to talk to families, we want them to trust us, and the best way to do that is to get accurate information. And so we take that part seriously. And then so we try to bring in the people who consult us to the meetings that we set up, and they often do come but their time is way more limited, so then we'll sort of talk out the issues. And then once a person's made choices or they decide they're going to go a certain route, we go back and communicate with the team. So it's a lot of coordination, but it's pretty challenging. And part of this, in the process, we also have to make sure that we have the decision makers at the table. So the patient's number one, and we have to make sure the patient has the capacity to understand this. And if they don't, then we need to find out who is their spokesperson. Is that what we're up next? Yeah.
So another part of what we do in our complex decision making is advanced care planning. So advanced care planning is just a part of the process. Really something that can happen. It's not specific to palliative care, but it's something that can happen at any point in life. And it consists of a couple different documents. The first document is an advanced directive document. Many of you may have seen this or may have not, the book, The Advanced Care Planning Guide. So a document like this is a legal document that allows patients, individuals, to designate a spokesperson for themselves. If something were to happen to you, this allows you to be able to say, if I can't talk for myself for some reason, whatever reason that may be, this is who I want talking for me, because we've talked about this together, and I know that they're going to speak and they're going to say what I would say if I could talk. So this is the first thing. It's called the durable power of attorney. This is the first part of an advanced directive. So this is a really important piece of information, and we'll get into the why. And the next part of it is the living will piece. So I don't know if you want to talk about that.
Yeah, that would be good. So the this whole, have you, just out of curiosity, do people, they must have seen these before and filled them out? I don't know. I'm not putting you on the spot on purpose. I'm only laughing because I do this, and I just did mine, like a few months ago. But this section really is called the living will, and it's really to talk about a future, hopefully way in the future state where a person may be near the end of their lives, or they call it permanently unconscious. And some people feel strongly that they always want everything possible done to keep alive. There are lots of reasons people feel that way. Other people, are more of the sort of quality, if I can't have a good quality of life and be at home and do the things I enjoy, I don't want to be resuscitated. I don't want to live on life support, those kinds of things. So, but believe it or not, a lot of people do these. Well, first of all, your doctor hands them to you in your if you're my age, Medicare wellness visit, and you go home with this document. Nobody really sits down and talks about it with you. And the other thing that we've had happen is people will fill this out very well, but they don't tell their powers of attorney that they're powers of attorney for healthcare. So then when we pick up the phone this person's like, oh, really? And so when that happens, it helps to have some indication of what you might want for your care. And it's the only other piece of this is that once it's done, it gets buried somewhere in your file cabinet or with your lawyer's office, or it gets scanned into our computer system where nobody knows where to find it. And it's sort of not a document that's portable or an in-the-moment document. To process this information takes time, and if someone's in an emergency, we have some other ways to help convey people's wishes. So, you want me to go through these?
Yeah,
Okay,
that's
so-
your favorite.
Okay, they're pink. I'm going to do both. So these are portable. Have you guys ever seen? I know Nancy has. And has anybody else seen these? Do you mind? First of all, we always have to ask because it's our job. Do you mind if we talk about death and dying? Because it does come up. Portable DNR means you don't want to be resuscitated if you're gone. That's what it means to me. Like if you go to fall asleep and EMS comes in and you don't have one of these, they're obligated right now to resuscitate. So that causes harm and very little benefit, maybe no benefit. So that's what this is. Now, what happened is people would show up in the ED with these. They'd be confused, they couldn't talk. And the ER doctors see this and they think, well, what do they want? What kind of treatment do they want? Because usually people who are DNR don't want to be on ventilators, but not always. And that's how we came up, or the whole country now uses this. It's called a POST form. It gets attached to this, and it lets you clarify in more detail what you'll accept for treatment. Some people just want to focus on comfort. They don't want a lot of tests. I mean, if they're in pain, give me pain medicines, but don't send me to the CAT scan or the cath lab or surgery. And other people say, if I'm gone, let me go, but if my heart's beating, keep me alive. And they'd go to the ICU and be on ventilators, and that's important information. So these act as provider orders for life-sustaining treatment, which means if no one's around to speak for this person, the doctors will use this as a guide. Yeah, it is. We're still working on our rollout. So, yeah.
So it's important for us to do advanced care planning. And one of the big keys of that is the first thing we had talked about with the advanced care planning and the advanced directive is nominating a durable power of attorney. Here's the reason why. So sometimes it's hard to have that discussion. It's really hard to stop and say, hey, let's talk about something as serious and not fun as this. What if this were to happen? What if something bad were to happen? Who wants to talk about that? I know I don't. But it's really important at every age, even being someone who's younger, coming from my age group. I have advanced directives already because this is really important. And here's why. If you don't have a durable power of attorney, so that is a legal document. If you nominate someone to be your speaker, we honor that because that's something that's you've signed, it's usually notarized, it's known as a legal document. We follow that, and we know that that's something that you've made a conscious decision, hopefully had that discussion with that person, and you've had that talk. You know they're going to have my back. They're going to use my voice. They're going to say what I've talked to them about, and they're going to respect my wishes no matter how hard that may be. So we go with that because we know that's the top, that's the best. We know that that's what you want. So we want to do that for you. We want to respect that. But what if we don't have that? Then what do we do if something happens? We have to use something next called a medical surrogate. So that's also another law. So New Hampshire has a statute that gives us temporary access to a surrogate decision maker. So that's not someone you choose. There's an actual list of who becomes the person's surrogate based off of what the law states, and it's a very specific order. So that goes to family members in a certain order. And from there, we have to go with whoever is the first person that we find and that fits in that. And we have to go through that kind of with a fine-tooth comb, and we do. That might not be the person that you want to speak for you. So that can be really challenging. They might not be someone that you've talked about your wishes with, or they might not be someone that knows what you would want, or maybe they're too emotional and they don't have the ability to respect those wishes and do that thing that you need them to do. Because it's really difficult. We know that. It can be really challenging. So that can be a really difficult thing. Also, the surrogacy law only gives that person the ability to make medical decisions here in the hospital for 180 days. What if something really catastrophic happened, and after 180 days, then what do? We have to go on to the third option, which is we actually have to pursue further legal things, and we have to find a guardian, which could be a family member that's willing to say, yes, I will take over this role permanently, or sometimes it's a state-appointed thing. So this is a lot, it's really heavy, but it's something to think about too, because I know when I think about things, I know in my family who I wouldn't want to make decisions for me, because I know how hard it would be if something happened to me, I got into a car accident and I couldn't talk for myself. I know my mom is my person. She would not be able to make rational decisions for me because she would be so emotionally attached. I know who I would want to make decisions for me. So I filled out advance directives so I can protect my mom as well. I know she would do right by me, but I know how hard of a burden that would be for her. So I did that. So it's just something to think about. It's something that we talk about here. It's good for us. It's good for us as people to have the right person for us. It's also good for our loved ones too.
Yeah, so we're going to say this simultaneously. We're a team.
We're a team.
We're a team. Yeah. And actually, the thing I love about palliative care, which is really, I think, unique in medicine, is we're an interdisciplinary team where basically the sum of the parts is greater than the whole. Did I say that right? Yeah.
Yeah, you did.
And so I still, all my life I've had trouble with that. But the truth is, we, in a fully staffed team, will have MDs, nurses, social work. We have spiritual care, chaplain, but it's not about religion. It's about the things we've been talking about all along, the existential distress. So much of our symptoms have this overlying suffering that spiritual care is fabulous with that. Some teams have pharmacists, and
some teams have nutritionists.
Some teams have nutritionists.
Like some really big, robust teams at very large hospitals.
Yeah. And we're structured. We have a daily interdisciplinary team meeting where we usually get centered with our chaplain and talk about our patients and plan for the day. And we try to respect each other. Everybody's supposed to have an equal voice. The providers tend to dominate, but we work on that. Yeah. And anyway, so it's nice, and we help problem solve together.
No, definitely. I think out of all the specialties I've had the ability to work in, palliative care really is very different in that, because everybody's kind of at the same level. We all have something that we bring together, but we really truly work as a very knit team, because if we don't all work together, we can't support the most important part of our team, which is every one of our patients and their families. So we all have pieces that we bring together, and we have different specialties and roles that we play, and that's how we're actually able to support such a, I don't want to say delicate, but complex kind of situation. So there's something that everybody brings, and we really do rely on each other for each piece. That's how we're able to pull together so much and really make an impact for each one of our patients and their families. And this is our team.
Yeah, I wonder, does anybody know Dr. Crosby from up in Laconia? You met her? She's wonderful. She's not here today, but she's based up there. She's a primary care physician and palliative care physician. There's me. Jody Goodrich, does anybody know her? She's our nurse practitioner. She's got.
Jody's
we were
been here
hoping
for a
she'd
long
be
time.
here, but she
was trying to pop in.
Carrying all the load today.
Yeah. And then I'm the nurse here in Concord. And then we also have a nurse, Mary Kaplan. She's up in Laconia. So right now that's our team. So we've got a couple people in Laconia, and then there's 3 of us here in Concord. We do have one other nurse practitioner who is taking a leave, but she will be coming back in January. So our team will grow again.
And we have a spot, or when we started our program, that was 2015, our chaplain was actually provided by the Granite VNA hospice program, and they've sent various people over. Unfortunately, our dear chaplain passed away unexpectedly, so that's why we don't have her up there. But that's a big thing we're missing, and our patients are missing. Yeah.
Especially us,
Yeah,
kept us centered.
Yeah.
So we're going to kind of switch gears a little bit and kind of talk about really how we do what we do. So I want to kind of open it up to you guys a little bit before we dive into another big, robust slide. I want you guys to think about maybe a family member or yourself or even somebody on a TV show. Think about this. Think about a person getting a brand new diagnosis of cancer. What does that make you think of? What do you think that looks like? Brand new diagnosis of cancer. What does that pop in your head as, like, what does that make you feel? Anything?
Confused.
Well, I think,
Yeah, confused, yes.
So,
I think it depends on your age.
Yeah,
You know, fear or,
fear,
yeah.
yes. I think at any age, maybe. Fear, confusion, maybe overwhelmed,
Vulnerable.
vulnerable. What do you think that person's going to have to go through at the very beginning?
Denial.
Denial. Lots of appointments.
uh,
Questioning, right? Why me? What next? What does this mean? Oh, we see something on this scan. We're not sure what it is. So we're talking.
That's worse.
That's the worst, right? So all these things going through your head. Next thing you know, you're going to see this person and that person. You're getting a biopsy. You're going to see this guy. You're getting labs drawn. You're getting scans here. And in the meantime, in the back of your brain, you're going, where am I supposed to be? What do I do next? Why me? What if this is cancer? What if this is really like, what if it's advanced? What if it's early? What does that mean? Am I going to get chemo? Am I going to lose my hair? Like all of the things. That's a really overwhelming thing, right? Just that one diagnosis. There's multiple other diagnoses, but I think everyone can kind of relate to cancer in a way because we see it a lot. So it's a lot. So that'll tell you about, really, think of that, and we'll explain how we can help.
yeah, I mean, the thing about, so there was, the thing about palliative care you're gathering, I'm sure, it's not the most sort of data-driven specialty. But there was an excellent study published in the New England Journal, I want to say 2010 or 12, where they took a controlled group at MGH of newly diagnosed advanced lung cancer patients. One group got palliative care and routine care early in the process, the part where Amy's talking, and then the other group didn't. And they found a significant improvement in quality of life in the group that got palliative care and a trend towards longer survival, which is pretty interesting. So we, it does make a difference, I think, we know, in outcomes, actually. And Amy, were we gonna talk, sorry, we only practiced up to a point. Did you wanna, should we just start talking about some cases?
Yeah.
I mean, the next, you wanna go to the next slide? Like who can benefit, or do you wanna say something?
So
This is how we do our
if
things.
we get involved early, we can help with a lot of that overwhelming kind of anxiety piece, especially. Because sometimes you don't know who to call. You're getting bounced around from place to place because you're going through all these different things, right? You don't know, okay, wait, am I supposed to call this one for that, or do I call that one for that, or where am I supposed to be today? What's actually going on? This is really overwhelming. I'm very stressed out. There's all these things, and then you might be having symptoms related to whatever's going on. So getting palliative involved early, we say that we can get involved at any age, any stage. The reason we get involved early is so that we can help. So instead of having that panic or not knowing who to call, sometimes it's, all right, you know what, I don't know who to call, I'm going to call palliative, because they'll probably know who to call.
Excuse me, where do you get your referrals? Or do you go looking for patients with diagnoses?
So we get our referrals, so they stem from many different places. Usually we get a lot from oncology for our cancer patients. The oncologist will meet with a patient and say, okay, they'll talk to our patient and say, what do you think about like a palliative consult? I think they can help you with symptoms and goals, and they'll talk about that. We get them in the hospital, primary care. We get our consults from a lot of places, and we'll dive into that a little more thoroughly. Yes.
Only if you've done, do you get referrals, like say from nursing homes? Do you get referrals from families?
We
No,
yes,
yeah.
we do.
Well, from families.
Yeah, and we used to get them from nursing homes, for sure. Yeah.
I'm only asking because I have a gentleman friend that I visit at Presidential Oak.
Yes.
When I visited him the other day, he says, you know, Janine, I think I've had it.
Ah,
And
yeah.
I did talk to him, and he was going to talk to his daughter about palliative care, so I have not contacted him since then.
Yeah.
I just wondered.
Yeah, no, we do, and you know, there was early on when we first started and people didn't really totally understand what we could do. There have actually developed some triggered reasons to refer to palliative care in all settings. But once I think the providers get to know what we do, then they'll ask us now.
Yeah, and we'll talk about that. We'll get into that detail too. But when we get involved early, it gives us a chance to help, and we can get to know our patients really early on. We can figure out who they are early on, and it allows us to build a good relationship. So I'll share a brief case of a patient that we got involved with really early. It was a young patient with a new diagnosis of cancer, and when they were in the hospital and they got a palliative consult, and palliative care came in and immediately panicked and thought, I'm dying today, which is not who we are, and was not ready to talk to us. So we brought our wonderful chaplain, Susan, in, and because we're interdisciplinary, Susan was able to go in and meet our patient and get to know them and get to know who they were. And Susan built a relationship with that patient. And palliative, the rest of us, the medical part of us, the clinical part, we didn't meet the patient. But Susan built this very wonderful relationship and trust with the patient. And they got better, they discharged and went to rehab and home. The next time they came into the hospital, it was worse. The cancer had progressed, the symptoms were worse. And we saw that the patient was back. We got another consult, hey, can you see this patient? We need help with symptoms, like really help us out. We brought Susan back, and Susan went in and said, hey, I'm happy to see you. Sorry you're back. Caught up with the patient as a person to person, and then said, what do you think about talking with our nurse? I know you weren't ready to talk with one of our providers, but what do you think about talking with the nurse? That allowed us to then get in again, and we talked about other things. And slowly, over the course of time, we built a really strong relationship so that when things got really difficult for our patient, we were then able to come in and fully support that patient. And we were then able to treat their symptoms. We were then able to talk about their goals. And we were able to make an impact for them. And as things got really, really difficult, we were able to pull in our hospice friends and really support them in their next chapter of their life. So that's one of the things that we do. If we get involved early too, we can build those relationships so that we can continue on the path with the patient no matter what, and support.
And
You
know, so that's one of, like, we all have our favorite cases, but I'm going to say this really fast because we do end up doing a lot of end-of-life work, but I think that we had these two cases. They were similar. They were young people with end-stage liver disease, and so they were at the point where they would need a liver transplant, or they weren't going to survive. And so we got called to see these patients because everyone thought they were going to go on hospice. It turned out both of them were already on transplant lists, but somehow that hadn't come through in the chart or the doctors talking to them. And they both actually were accepted. Then once the hospitalists knew that they were on the transplant list, they both were transferred, got their transplants, and they're both doing really well. One is a father of a young son, and the other was, believe it or not, actually a refugee from the DRC. But so he's doing great. And so that was another example of, we have our cases that we feel like
They don't all end sad.
yeah, and yet they, but again, we just go in and we talk to the patient and they tell us what they need.
Yeah.
So where are we now? Let's see.
Who can benefit from palliative care?
Okay. Yeah.
Fragmented.
Yeah, I am. Can we go to the next one? Because we already talked about that,
did.
right? Yeah. So when you think about what we do in the hospital, you were talking about, we actually get called by everybody now, surgeons, hospitalists, pulmonary critical care, cardiology, and we basically, when we can sit down, I think we've already actually talked about this, but we coordinate the care plans, we advocate for the patients, and the thing I think I'm going to talk about, you understand what we do with our patients, but we also, for the organization, save a lot of money. So CAPC, the Center to Advance Palliative Care, was founded around the time that palliative care became a specialty. And they're nationwide, and they do a lot of data collection, a lot of research. And they've actually discovered that per inpatient consult, for a single patient who gets a palliative care consult, will save roughly $3,000 per admission, because of just sort of like adjusting care to what they need. And actually, depending on the size of your program, we think our program, we don't have the actual data, but based on the calculations, probably save like up to almost $3 million a year. Not the problem, but that includes that's over and above the cost of paying for us. But the tricky thing is capturing that data, because it's we don't see that many patients in one sitting. The value we bring is in actually tailoring, often reducing a lot of interventions and tests and getting people on the track they want to be. And have you guys heard of the Institute for Healthcare Improvement, IHI? Yeah. So they have lots of wonderful white papers. They started out as a quality, maybe do you work with them? Or? Yeah, so they started out as a quality improvement organization, and they have a white paper that talks about, it's called Achieving Hospital-Wide Patient Flow. Now, this is all like the latest admin. It is, but it isn't. So especially with COVID, patient flow talks about being in the right place in the hospital at the right time and getting the right treatment based on your goals of care. And that got really jumbled, even worse than usual during COVID. And so now a lot of hospitals are looking at that. But palliative care is one of the drivers of that. And we try to take that to heart. So that's what we do in the hospital. Yeah. And then outpatient, you were asking about outpatient referrals. One area that's kind of interesting is people with sort of dementia, moderate, mild dementia, out in the community living at home with a caregiver. The caregivers can get a lot of stress in that setting. And so primary care doctors will refer them to us. And we just sit down and kind of talk things through. A lot of times neurologists, I don't think, always explain to patients and families what to expect with the illness. And we try, and it does help to kind of know what to expect and have a plan in place. And then the caregiver stress is big, and we also try to connect people with resources if they don't have them. But we should, let's see, what's 20 of? What's next? Yeah.
How does the loved one fit in with the patient, with your care?
You tell me more what you're asking. Yeah.
Well, patient's seriously ill.
Yeah.
And you people come in. What about the loved one that's going along with the patient that cares about whether they live or die?
Oh, that's a great question. So what we usually start with is we try to get everybody involved with that patient sitting at the table with the patient if they're able to talk. And then we try to listen. In fact, that's why I'm kind of getting a little antsy, because we're supposed to listen more than we talk. That's why this is hard for me. And so basically, we try to hear from the loved ones, what do you think? What's hard about this for you? What are you most worried about? Make sure the loved ones understand what the doctors are saying. Is that kind of what you were getting at?
Yeah.
But
Pretty much.
yeah, and a lot of times what we find is patients' loved ones are their voices. We just had a case this week of, it's kind of heartbreaking sometimes, like the loved one, the person who's the caregiver knows that this person doesn't want to live like this, but for some reason the patient ends in the hospital. And
How do you get involved if we or our loved one needs that kind of care.
Oh,
And we don't know of it.
Yeah.
you-
Who's around to suggest, say, you know, this kind of care that might help?
right, so people can call our office directly. The visiting nurses sometimes link patients to us. Primary care doctors can help, or if a person ends up in the emergency room or hospital, people can ask for us. Is that what you were asking?
Or how do people find out about us?
Yeah.
Is that what you're asking? How do people
When
find out about
you
it?
don't know about it, and you're not thinking clear,
Yeah,
you know, and you want to help your loved one,
yeah.
who's there to jump in and give suggestions or say, you know, we have these people who can help you out?
Yeah, yeah. I mean,
That's part of the
Yeah.
education that is continuous with all of the, we call them like the referral sources. That's ongoing education all the time with these people that should be coming into contact with you all in the community. Like, again, primary care, maybe visiting nurses, you know, other places that think of how we can support and stuff. So palliative care is out there. It's just a matter of someone thinking, you know, this might work. And then how do we get you hooked up with it? So it can be complicated, just like anything. Got to have the right person to think, maybe this will help. Primary care does try to do a pretty good job of this, and we have really good response from them, but
have you heard about palliative care? Did you guys kind of know what palliative care is? This is new.
I heard about it years ago, but nothing was ever explained.
Yeah, yeah, yeah.
I have a couple of questions. I've filled out all the forms. It's supposedly in my chart somewhere. If I show up at the emergency room and can't tell you, go look for it, how, and I say I have a DNA, I think I should have it tattooed. Because you're gonna start something that I don't want before you find it in the record somewhere, if it's there.
right.
I assume it's there. And my other question is, how do you bill for what you do?
Yeah, that's a great question.
It's a big one.
So for the first
I was going
question,
to say, I can talk about the DNR.
yeah,
So DNR is always a hard one. Having a portable is usually the best, but most people don't keep that in their car.
but you do have a wallet card at the
Yep.
bottom.
So that's something to keep. Making sure that your loved ones know. Because when you get entered into the system, let's say you come in through the emergency room, I can tell you this because I used to work down there. Our system, when we pull you back in, it doesn't populate a code status right away. So we'll look at these things. We'll look through registration and go, is there an advanced directive? Do we know that there's a portable on file? Like, we'll look at some of those things, and we'll try to look at previous code status. We do our best, but nobody's perfect. So we do our best. And
No
typically,
texting, yeah.
you know, tell all your loved ones, anyone that they might be looking. And usually when you come in, like for routine visits at PCPs or things like that, if it's within our system, they're constantly asking you, and I have so-and-so as your emergency contact, is that correct? When you verify those things and make sure you have the right number and stuff, that's the first person we're gonna call. And we're gonna say things like, do you know if? So make sure your emergency contact knows, hey, she's a DNR, and that's really important to her, because they're gonna be like, hey, she's a DNR, that's very important to her. And they will take that word, okay? And then, I don't know if you want to talk about the second part of her question.
Yeah, on the billing? Yeah, so basically only providers can bill like a physician or a nurse practitioner. And the billing is kind of under the Medicare umbrella usually, and you know, it's time-based. And that's why I brought that thing up earlier about what the research of the cost savings, because if you just look at our billing, it's not going to look like we're paying for ourselves if you just look at the billing. And so you really have to take into account the whole picture, and then we're very, you know, valuable, but or we pay for ourselves, I should say. That's my goal, yeah, and save the money, organization.
Yes.
Just to add about the DNR situation, this doesn't cover everything, but if you have a copy of your DNR and a copy of the post, your current medications, and from list of what you've got on your refrigerator, because if somebody calls 911 and they see that, there won't be anything.
Yes.
So you really have to start there.
Yeah.
Why don't you put nice pictures on it?
I know.
I know. You can,
DNR.
But if you're ever at home, that's the first place EMS goes. They go straight to the fridge. They're trained for that.
oh, yeah,
Or
or
they'll always look at the fridge, and they're looking for the hot pink because that's the color.
you can put it next to the door.
That red plastic thing that says bylaws officer.
Yes.
Yeah,
Hot pink.
yeah.
Yes.
Are you overwhelmed? Is there enough staff to do
Oh,
this?
oh my
How
goodness.
do you get your respite care?
That's so That's so great. You know, I've done this, as you know, for a while, and it does get to be emotionally draining, as you can imagine. And this program is designed to keep everybody afloat. So when we're staffed, the way this was originally set up in 2015 with spiritual care and social work, we work like 4 10-hour days, which, you know, we always work more, but the point is they build into it. You know, we wish we could give weekend coverage, but we don't right now. We're a consulting service only. And the staffing, I think, was actually just right for what we needed to do, but we've recently, that thing you just were brought up, we somehow got into the programs that weren't like profitable enough, I'm assuming, because now we're cut in half and now we are actually struggling a little bit. So we're hoping that'll be a temporary thing and we'll get back to what we were. Yeah, yeah, yeah.
Yeah, we've had to change our focus a little bit,
Yeah,
and still we focus very much and strive to provide the absolute best patient care possible. So our focus definitely is where we know we're absolutely the most needed. You know, we always want to be all the things, all the places, and we know that there's places that we could do so much more and places that we have done more in the past. But we're being very thoughtful about where we're putting our time right now. So one of the things that we've done recently is we've embedded ourselves in the ICU to make a really good, fast, quick impact in a high pressure setting, and it has been very challenging but very rewarding, and we're making sure that we're supporting our patients to the best of our abilities while we work on regrowing.
Yeah, we're hoping to get back into nursing homes. Jody used to go to Pres Oaks and Pleasant View and Harris Hill. That was good work. And we used to be able to see patients after they left the hospital, so we'd have sort of a longitudinal relationship. So we're hoping we'll get there again. We haven't given up hope. We're all about hope.
We are.
You may not think so, yeah.
Which ties us into our last little bit here. So we love and support our organization, and you know, we know that they love and support us as well, because what we do for our patients is huge. We're all about our patients in the community and what we can do to better our patient care and to really focus on the patient, because that's what we're here for. That's what Concord Hospital is here for. We're here to exist to serve our patients. So things that we have done as a group with our organization is we've implemented a standardized workflow on improving end of life here in the hospital, which was a really big undertaking for us. So we've actually, I know we're the only hospital in New Hampshire right now that has a standardized workflow of how to implement end of life care in a nice process that makes sure that we're covering all the things that we need to do to make sure we're ensuring the utmost comfort and keeping all the family members and the patient at the forefront of our care. And it's been a really wonderful undertaking that we've come on, and we've seen a really great improvement in how we deliver end-of-life care, so that's been great. We're actively involved on a regular basis in quality and process improvement, so we've been working on improved strategies for pain management and how we deliver pain management, which has been really, really cool as well. And we're currently working on and finalizing a big plan to improve our pain scales here, because that's a really important part of how we make sure that we're properly doing good symptom control. So that's been a really big thing. And especially focusing on being able to control pain on our patients that can't actually say whether they're in pain or not, whether they have a delirium or some kind of underlying cognitive disorder or dementia, or whether they're at end of life. So there's lots of studies that we've found, and we're implementing some big things, so it's really exciting. We do ongoing education with the organization as a whole to assist our providers across all our different settings and specialties, our hospitalist team, our family health center and their residents, primary care, everything, so that they know about palliative care, and we help them hone their palliative skills so that they can do some primary palliative themselves. We do new graduate nurse education because this is not something that's taught in nursing school. So we're trying to help our nurses get right out of the gate and learn how to talk about palliative care to make it not so scary and understand hospice and end of life. All of our providers are board certified, and so are our nurses. That's really exciting. I know we're, a smaller team, but it's still a really big thing for us to have everybody certified in our specialty. So it's kind of a cool thing. We're members in the organization of many committees. We're on the ethics committee. We are on the cancer committee. We are on our clinical practice committee for here and the other 2 campuses in Laconia and Franklin as well, and so many more. And that keeps us, as part of making sure that we're improving how we do what we do and improving the care of our patients. And last, we closely really collaborate with a lot of community partners. We work with hospice agencies, all of them. We work with multiple different VNAs to help with, transitions in care out of the hospital. We've worked with a lot of skilled nursing facilities and still do. We call and talk with them. We've worked with Riverbend in the past, as well as New Hampshire Healthy Families and so many more. So.
And I have to add, because thanks for coming. So Dom just worked, Dr. Gefkin, who works with the residency program, that's the other group. We have your question about how do we sustain ourselves. We have this whole wish list of things we want to do, and we wanted to get more involved with the residency. That we love working with them. And then the other thing is all these color code. I find that we'll go out and teach like practice groups about these, and then within a few years they totally forget. So we need to continually go out there and work with our primary care, because some of palliative care, there's a primary palliative skill set, and Nancy will know about this, and it's that people can learn. It's like, and you can just get started with your PCP if they know what to ask, and so that's what we try to do. Yeah.
Something close a little while ago. You're one team.
Yeah.
You're not representative of several teams. You're one team.
Mm-hmm.
I don't know how you do it.
Amy's a big part of it.
We figure it out.
Yeah.
It's labor of love.
Yeah, it is. It's
why.
a lot of.
That's how we do it.
You get kind of hooked in with your patients. Are we gonna
And
say
each other.
something, Nancy?
So I'd just like to add, at one point I was a provider as well, but as far as the pulse goes, it's very important. And if you think about it, say your primary care provider is on vacation. This helps whoever is taking call to direct the care. And so it's very important. Your primary care person has so much on their plate to talk to you about. But if you bring this up, then that can trigger the conversation.
Thanks, you guys.
I have a question. Do you have any copies of that form for your power of attorney?
Yes, we do.
It's
I brought a bunch.
Thanks, you guys have.
Thank you so much
Yeah.
for listening to us. Like I
Yeah.
said,
Yeah, we
we're very
appreciate you.
passionate, so thank you for taking this time.
Well, thank you very much, both Dr. Eckert and Amy, for presenting today, and thank you for coming. Our next presentation is December 8th, and our guest speaker will be Dr. Melissa Hoyt, and Dr. Hoyt is from Concord Surgical Associates, and she will be talking on thyroid. So have a great weekend, and thanks again.
Thanks, thank you.